And I didn't give myself one. So when you're done, you guys are gonna have to read me the questions. Okay, so I'm just gonna do 2 more minutes and then we'll talk about the quiz. Okay, so I don't have one up here. So somebody read me the first question.
The following is a prominent complication of type 2 diabetes.
And what were the options? Or just tell me, what did you guys think was the right answer? What were the options? So, and which one did you select? A, yeah. So yeah, our atherosclerosis, that is a very prominent complication from diabetes. So liver, and did it say both type 1? What did the question say, type 1 and type 2? Is it so type 2 specifically? That's more common for type 2. What was the next question?
Neuropathy is a complication that can occur in which type of diabetes? I think both.
Anyone else what did everyone think? Both? Yep. So that one is going to be show up in both type 1 and type 2. And what was the next question? Sulfonylureas, I know. This is the funniest word.
Only type 1
True or false? False. False. Yeah. Yeah. Insulin is for 1, and those are hypoglycemic. So those are more for type 2. Type 1 is just going to use insulin always. That's totally exactly. It's totally this stuff. You've had a big gap and you've learned a lot. So this is reinforcement, and you guys will just see why you just kind of talk about the same things over and over, and you see a lot of diabetic patients. So it'll become second nature in no time. Okay, was it fourth question?
Kinds of hypoglycemia include which of the following? Rapid onset, tremors, and you skin both.
Yeah, both A and C. So hypo comes on fast. People can be hyperglycemic for years. and they don't necessarily feel sick, and they can have damage to their organs, but they don't necessarily feel sick. But hypo, you feel pretty crappy pretty fast. And so that comes on fast. And clammy skin and kind of racing heart and things like, and then the rapid breathing, those things. It feels like anxiety to me. That's what kind of like nauseous anxiety. Although nauseous can be from hyper as well. And then what was the last one?
Consider 70 milliliters.
Or did we miss one?
No, that's the last one.
That is the last one?
Yeah.
Isn't there one about a medical emergency?
No.
Oh.
You can make one up.
I'm thinking of something else, I guess. Okay, what was it again? 70 microliters per deciliter or milligrams per deciliter. True or false? True. Yeah, 70 and below is hypoglycemic, which some people live below 70. I don't know. I think it's it might be more normal, but in general, if you are in the 80s, 90s, and then you dip below 70, you'll notice it. Okay, good. So yeah,
What is the number for hyper starting out with?
it's usually anything above like 120, but like 140. We have numbers here though that we'll go over. I think it's 140 is maybe the true hyperglycemic. But we have those numbers. So I'm gonna go into the PowerPoint slide. There's 32 slides, you guys, and I'm gonna hopefully you can just glance over here and see sorry that it's not right in front of you. I hate that. You guys can't see it in front of you. So these are the objectives. Hopefully they lay over the objectives that I printed out. They were supposed to, and that's part of what I have to check for the previous classes. If there's a question as, well, do I answer the objectives in the PowerPoint or the one in the Moodle? Just do the one in the Moodle that's like set aside as a separate document. Do those objectives if you ever miss the class, because sometimes there may be objectives that got into a PowerPoint that have been there for years and I just didn't sync it perfectly. So just always do the ones that are in the Moodle page. So we've had some changes to the guidelines, and I think Gail went over this a little bit. So blood glucose or checking we call it the A1C, but the HbA1c is the bigger official term. We want to know that level. That's a snapshot over a course of 3 months, because the little red blood cells live for that long. And so it kind of tells a story of what's been going on in the blood over the course of so many months. That's what the A1C reading is. So that's why we want to see it, because it doesn't just tell us what's happening like right that second. So we've had some changes. We kind of debated about it. We dismiss a lot of patients in our clinics because they have they're hyperglycemic, but it might not be that big of a deal. So it's a big kind of debate. Capstone groups have talked about this, but we found literature from a really good comprehensive thing out of Canada, that because there's not a lot of like hard guidance on this. But we did find some good stuff from a dental hygiene school in Canada, and it's pretty comprehensive. And so we're just gonna sort of mimic theirs, because it seems like theirs is very close to what ours were, with just a little wiggle room. So we kind of feel like we align with them anyways. So well-controlled typically is considered 7% or less for the A1C. If they're elderly, we let them go up a little bit higher, because it's harder to control blood glucose when you're older. So 8% or less. But then the clinic cutoff, which this is like crazy high. Somebody who has an 11 is pretty close to uncontrolled. I mean, I don't know, if I had somebody in my chair in private practice, I would have been like, oh no, you're not controlled at all. But that's our cutoff. So if they're above 11% A1C, then we're not going to see them, because they're just too much at risk for infection, and we just don't want if we're not going to get good results, we don't want to go through all this process. We'd rather have them try to bring that down a little bit before we start the process of care. So their maximum blood glucose for an adult with 7 or less is 240. So that's a little higher than what we did before. So before the cutoff was 200, but now we're saying, okay, if overall you're at a 7, you're pretty well controlled. So if today you come in and you're 225, it's okay. We'll still go with it. And I love that because that gives us a little bit more wiggle room. Because some people are literally like 201 or something like that, you know, and then you're like, oops, sorry. And then adults above 7%, but less than 11.2, or above 8 if they're elderly to 11.2, it's the same 200. So it's the tricky part here is that we never talked so much about the levels of A1C as much, like with I think 7 was always sort of something that we hit as a number, but we didn't talk about the 11, that's new. And I do think we did 7.5 or 8 for elderly in previous years. But the big thing is educating your patients on the importance of getting an current A1C in for us to be able to see, because once we have that on record, that helps a lot. It gives us a better idea of where they're at with their diabetes. Okay, so I'm gonna go to the next slide here. So diabetes, so just a little bit of background. It's pretty common. Yeah, Jenny, go ahead.
Sorry, for the other last slide, for the 11.1%, and then that with the, physician, or like a physician's note or something.
Oh, if they're up to 11,
Yeah.
I do think that there was a thing in the manual that says that anybody with diabetes needs a medical consult. Did Gail tell you guys that? So I thought anybody, and maybe we might have to double check it, but I thought I read that anybody with diabetes needs a medical consult. So if they have 11 A1C, you'd be doing that anyways. You'd say, okay, I have Judy in the chair today. You might call the physician, say, you know, just checking that everything's okay and we're good to go. We scheduled this scaling and root planning procedure with local anesthetic. And so you might be doing that call anyways, or getting an approval from the physician that they're good to go, that they're okay to see. Does that not sound familiar?
No.
Just because you didn't know about
Yeah, I didn't
the
know.
position.
Had to, like, I thought it was just if they were like up to 11 is fine,
Yeah.
but like they would have to be.
Yeah, we can double check the clinic manual because it could be that you don't actually have to contact the physician. I just thought I read something about all patients need a medical consult when they have diabetes, and it could be that I read something else. So we'll check but you guys all read the clinic manual, right? And so we all fine that we read it.
We write the consult and give it to them so they could go follow up with their finance.
Oh, that
That's
could
what
be
I
what
did
it
with my
is.
patient. He's diabetic, and so even though he was like that high, I had to write a medical consult and then for him
To his physician. We can double check. We'll look at the manual. We can look at it after class or on the break. Okay, so diabetes is prevalent. Diabetes is not rare. We talked about this in oral med. It's the 7th leading cause of death in the US. And really, it's probably underreported. There's a lot of people walking around with prediabetes and they don't know. But it's characterized by hyperglycemia. That's what sort of triggers, that's the sign sort of that the body is saying there's something wrong. Something might have been happening for years previous. But that hyperglycemic, that elevated level of glucose in the blood is what kind of signals that there's a disease process going on. So abnormal increase in blood glucose, either there's no insulin or there's too little insulin secreted, or there's some kind of a defect in the cell where it's not working with the insulin. So it's just not, it's not utilizing the insulin appropriately, or it could be a combination of both. Somebody who's type 2 could start to need insulin because their body could just sort of, you know, poop out on them after a while and just say, you know, I just can't do this anymore. And so it can be a combination of both. So we want to think about in terms of your role. So it's wonderful to know about the disease. It's sort of necessary to know things about the disease. But more than that, you just want to know what's your role as a hygienist. So you always conduct a periodontal assessment, or a risk assessment, but you have to know that on the forefront of your mind that those patients that you see that have diabetes are at higher risk for periodontal disease, and that their periodontal disease affects their diabetes. So this is like top of the, cream of the crop information that you want to know as a clinician. So you want to determine the need for co-management. Is there somebody else that needs to be a part of this treatment, or is it something that you can handle in-house? And that could be a specialist, that could be the physician, that could be family members or diabetic counselors, or, it could be a host of different people. Monitor the pharmacological history for drug interactions with glucose control. So just being familiar with their medication list, type them into lexicon and refresh yourself. There's so many medications, nobody expects us to memorize all of them. So, but just know how to resource that information, and know that it's all kind of important. It might all matter. So, you read it and sometimes you're like, okay, well, they wrote it, so now I'm just going to move on. But maybe you need to just check and see if there's some kind of a reaction. Minimize potential risk for emergencies. So talking to them about what they ate, when they took their medicine, what time of day, are they feeling stressed? So you want to know these things about your patient so that you minimize the chance of there being a medical emergency in your chair. Detect undiagnosed and uncontrolled diabetes and refer. So knowing some of these cardinal signs that we've talked about last year, and then being able to say, hey, you might have something going on. You might want to check out with your physician. Modify the dental hygiene care plan on the basis of the patient's need, and then monitor the outcomes of dental hygiene. So evaluate. So those are all pretty standard. Pre-diabetes, so it precedes type 2. So there's really probably not a pre-type 1, although I suppose like technically there could be. You just really, you wouldn't really know about it. Whereas pre-type 2, you could know about it, because you could have a few signs or symptoms, or you could just know that it runs in the family. And so you're going to go get it checked out. Like I'm going to have my glucose monitored because I know that my diet's maybe not what it should be, and my mom and dad both have type 2 or something like that. High risk for developing diabetes and cardiovascular disease. So if they're pre-diabetic, they're just, obviously that's kind of says it without needing to say it, is that they are higher risk of going into full-blown diabetes type 2, and in general cardiovascular problems, whatever they may be. Associated with abdominal obesity, high triglyceride levels, low the LDL, the good or HDL, high density lipoproteins, and then hypertension. So all of those things are associated with, so if somebody has low good cholesterol and high blood pressure, they're just sort of more at risk of developing diabetes. So they're sort of in a risk factor group. There's not necessarily symptoms. They could feel totally fine. Lifestyle changes, monitoring their status, possible introduction of medications to reduce the incidence. So usually it's something that you wouldn't, in pre-diabetes, you wouldn't necessarily have to go into the medication. You could just change some things in the lifestyle. Slight change in diet or more exercise can go a long way. So 5% of adults have type 1, so it's much less. The vast majority of adults have type 2. So you won't see type 1 patients as often as you will see type 2. And then it presents during childhood. They used to call it, remember, juvenile and adult. It was a juvenile and then adult onset diabetes was type 2. And then they just went to type 1 and type 2. But usually it presents during childhood or teen years. And then body does not produce insulin. It's lifelong. If nothing grows back, you're not going to, be able to get out of that. It's a lifelong condition, and you'll always be dependent on the insulin. And then it's difficult to control. Like, you see a lot of people with the pumps, just to be able to, but one of my friends, she was just recently, she's an adult, she's in her 50s, and she got type 1, a very rare form that she developed during the pandemic. And she has a little pump, but she has a long acting and a short acting, and she mixed them up. So she gave herself the short acting when she went to bed. So she had to like, oh no, she gave herself the long acting when she went to bed. I don't know. I'm confused. But anyway, she had to get up and eat like every 2 hours, whatever one that would be. She had to get up and eat. It might have been the long acting because she's going to have insulin, but she needs food to burn the insulin. Like you can't have no food and then give yourself a ton of insulin. That's a problem. That kicks you into a medical emergency. So I think she had to get up and eat, is I think what she said. Anyways. So, but they try to keep them stable with the like the automatic delivery systems, and those have helped, but they can be a wide fluctuation of their glucose levels. So the origin of that is typically genetic. It can be an environmental, it can be an autoimmune or a viral reaction, or it can be like sometimes it can be medicine induced also. And then, so type 2 diabetes, that's the most common form. Most 95%, 90 to 95% of people with type 2 insulin resistant. So they might have enough insulin, but their body's just not using it very good. So they just are resistant to the insulin, or the insulin secretory, whatever, defect. So they're not secreting insulin very good. So they're not using it or they're not secreting it very good. Typically preventable for most, lifestyle, we talked about that. These are the risk factors. We kind of talked about that too. And somebody can be walking around with prediabetes for, up to 10 years without having signs and symptoms. We sort of talked about that. So it develops very slowly. Your body acclimates to hyperglycemia. It sort of acclimates to it like, not too crazy. Whereas hypo, your body doesn't acclimate. It's like, woo, that's not okay. And that's why you get that rapid onset and it feels so weird so fast. Any questions? You guys good? Yeah.
So if you've had, diabetes, then this is that you're at higher risk.
You are higher risk. So if you've had like gestational diabetes during your pregnancies, it does increase your risk of type 2. Doesn't mean you'll get type 2, but you just are a little bit higher risk of getting it.
Does that just mean like you were prone in the beginning anyway?
It might be, or all those pregnancy hormones, they react to insulin, and that's what happens is, somebody who may be more genetically predispositioned to it in the first place, it just kind of kicks it in while you're pregnant, and then usually it resolves itself, but sometimes it doesn't, and that I think it does probably have to do with like your predisposition to it. Okay, so 4% of pregnancies in the US, I kind of want to check that number and see if that's still the same, because I think that's like a 2018-19 number. But anyways, it's not a huge number of people pregnant who get gestational diabetes. High risk individuals, so if family members have had it, and then this glucosuria, they check every time you go to the doctor when you're pregnant. Every time you go in, they check your pee. So they're checking for proteins and glucose in the urine. Generally reverts after the mother gives birth. Pregnancy hormones have an anti-insulin effect. So they sort of make your body not respond so good to the insulin that you're making. And so you tend to become hyperglycemic and that's just not healthy for the baby if you're too high, if your glucose levels are too high, it's just not healthy for the baby. And you're just not utilizing your insulin as well in those cases. Increased risk of developing type 2, 10 to 20 years down the road. So you can, and then increased risk of perinatal morbidity and maternal complications, cesarean and hypertension. Oh my gosh, when the mother is really preeclampsia. That's what my friend had that really bad at the end of her pregnancy. And then other types of diabetes, I sort of touched on this, they can be associated with like genetic defects of the beta cells in the pancreas, or if somebody has pancreatic disease or an endocrine disease, or a chemical induced agent, like some kind of a medication that triggers that diabetes state or genetic syndrome. So those are all a little bit far more rare and uncommon. So here's some guidelines. These are some numbers for like Tala, what you were asking. So the green is normal. So in like a healthy person who's not pre-diabetic or doesn't have their A1C should be more in the 5 range. That's kind of like a baseline normal, with somewhere around under 100 for a blood glucose. So like when we were doing our blood glucose, when we were practicing to use the glucometers, some people were 99, some people were 89, like just in that range is normal. If you just ate something, you might spike for a minute, but you go down pretty normally and rapidly. And that would be, this is the fasting. And this, oh shoot, I had these written down. One is the fasting and OGTT. Oral glucose. Yes, thank you. Thank you. That's the drink where I think you drink something for both of them, but that's the one where you drink. It's like a fizzyless orange soda, or they give you, and it's like a drink, this thing, they make you drink it all at once, and then they test your blood sugar. And then the fasting, you don't eat anything for like 8 hours or more, and then they give you like 4 of those drinks. Oh, I had that because my blood glucose was high, and so they wanted to make sure I didn't have gestational diabetes when I was pregnant with Lola. So I had to do the fasting. I felt yuck. I did not. I was so like, and I was like, I don't like this. And she's like, I know it's kind of yucky. I'm like, what are you doing to me? And then I ended up not having gestational diabetes. So I'm like, why did I think I don't know, maybe I ate too much sugar that morning or something. So, and then prediabetes is in the yellow range, and then diabetes is in the red range up at the top. Okay. So reminders to use just diabetes sort of background reminders. So to use glucose, we need to have insulin. It's the key. That's what, remember, we would call it like the key. It kind of it opens up the cell and allows your cell to use the fuel. So we need insulin to like carry it in there, carry it out into the body. So it sort of gives your body the ability to utilize the fuel. So we call insulin kind of like the key. A person with diabetes either produces too little or not enough. There's something going on. And insulin is a hormone. So it's an anabolic hormone, and it's produced in the pancreas. Those beta cells, or the Langerhorn. Yes. Yes. Kind of funny name stuff. So these are common symptoms. A fruity or an acetone, you'll know it. Like if you're be used to perio breath, and there's gonna be all kinds of things that you guys will be used to. But when you smell like a fruity smell, I had a patient one time who was an alcoholic, and I was like, am I like, I think that's alcohol on his breath. But then I had another patient that was just like a guy that came in, and I didn't know of any issues he had, and he had such a distinct fruity smell. And so we kind of had a little bit of a discussion about that, and he had some family history, but he didn't. And this was when I was first starting out, and I had, I certainly wasn't teaching, and so I didn't think about nailing it home like, you should go to your doctor, because that's not, nowadays I would probably be a little bit more assertive, but I did bring it up to him, and he did have some family history of diabetes. So hopefully, and I only saw him that one time because I was at the perio practice, so we didn't always see patients long term. But anyway, so fruity acetone breath, frequent urination, excess thirst, unusual hunger, rapid weight loss, weakness, and nausea. So some of these obviously overlap with all kinds of things, but if these things are sort of like, you get a couple of these going and they're sort of coming back again and again, then these are signs that the patient, you could help the patient say, a lot of these are signs of diabetes. You may want to see your physician. Dry skin, mucous membrane, flushed facial appearance, abdominal tenderness, rapid deep breathing, and depressed sensory perception. So maybe some beginnings of some neuropathy if they're not feeling as sensitive on their fingers and feet. So some chronic complication of diabetes, micro and vascular, micro micro and vascular disease. So micro would be like eyes and affecting the kidneys. Macro would be like the heart, and like atherosclerosis and that sort of thing. Diabetic retinopathy with potential vision loss. Nephropathy leading to renal failure, so affecting the kidneys, the blood supply to the kidneys. Peripheral neuropathy, foot ulcers, that poor wound healing, especially if they get an injury on their foot, or if they also just aren't, their feet will feel less sensitive, so they might not be aware of an injury on their foot. Yeah.
My sister-in-law used to caregive for somebody and they had uncontrolled diabetes and they had to get like their toes. Like,
It's very sad. There's a young woman in my church and she didn't realize that something was happening on her foot, the same thing. And she's younger than I am. And she ended up, then when she noticed it, she got scared and she didn't want to go to the doctor. It was like this whole thing. And then it finally ended up with some toes getting amputated. It's really sad. And she was, I think, uncontrolled diabetic. And then neuropathic joint disease, autonomic neuropathy, so they can have gastrointestinal issues or genitourinary issues, sexual dysfunction. So anything where small nerves and blood vessels are being affected can affect all sorts of areas of the body. And periodontal disease, of course, as well, which is biggie for us. That should probably be at the top of the list since we care most about that. So there's going to be a higher incidence of atherosclerosis, cardiovascular disease, peripheral vascular disease, cerebrovascular, anything that has anything to do with vascular. They're going to have a higher hypertension, that's vascular as well, abnormalities in lipoprotein, their HDL and LDL, and then periodontal disease. So there are lots of higher risk for these situations. Chronic complications. So typically, if it's type 1, we're going to see more kidney and eye disease. And if it's type 2, they're going to have more heart disease, more cardiovascular issues. And then neuropathy, the nerves, the tingling and numbness in the hands and feet and extremities, that's going to be for both. But these conditions are not exclusive. It's just more common. So that's just a little more common in that, one than the other. Okay, so periodontal disease in the diabetic patient. So the prevalence and severity of periodontal disease increases for both type 1 and type 2. So these are all, there's lots of slides here with just concentrated bulleted information that is good to know. I tried to weed out like the nice to know and just kind of put in what you want to know for when you're seeing your patients and what you want to understand. So obviously it increases their risk of perio. A1C is greater than an 8. They're going to have even more increase because that means their blood glucose is not as well controlled. And if their blood glucose isn't well controlled, then their periodontal disease is probably not very well controlled either. Glycemic control is an integral part of controlling perio. And then hyperglycemia leads to increased pro-inflammatory cytokines. There's a lot of, like maybe you've heard the term cytokine storm. It's like your body is just overrun with the inflammatory mediators in the body, and that a little bit is good, a lot is not good. And so if you're hyperglycemic, it kind of increases those pro-inflammatory cytokines. And that can destroy connective tissue and bone, thus periodontal disease. But it can also affect other parts of the body. Positive outcomes, not always. So the next slide here, periodontal disease and the diabetic patient. So positive outcomes, not always typical when you're doing an SRP. So you might go to town and do your best job with your SRP, and you might not get the most wonderful results that you were hoping for. I mean, you might get some, but some areas might not respond as well. Debridement and biofilm control for the diabetic patient is just imperative because that's going to help kind of get over that hurdle a little bit, or that little bit of a disadvantage. Removal of hard and soft tissue deposits are crucial. So we still want to treat our diabetic patients probably more than anybody. That's where the argument comes in. And it's like, well, if I'm telling my diabetic patient, sorry, I can't treat you because your blood glucose is too high, then they got this infection, and infection raises their risk of so many things when they're diabetic patients. So, patients with diabetes, my person first. So it's kind of a hard thing, but, thorough SRP is indicated for, diabetic patients with diabetes. Now I have to go through and change all the things because I'm supposed to do the person first. I got to go through and make sure I've done that. There is supporting evidence for things like the doxycycline. You guys remember we talked about that in oral med. It's that low dose antibiotic. It's such a low dose of an antibiotic that it's not even really classified as antibiotic. It's it affects the connective tissue more. So it's doxycycline. So just 20 milligrams of doxycycline in conjunction with SRP. There's been studies that show that's very helpful. Antibiotic pre-medication is not an automatic requirement. So just because they're diabetic, that shouldn't necessarily raise your red flag. They need to be pre-med. And then there's some controversy with the epinephrine. Sometimes we're scared to give our diabetic patients local anesthetic with epinephrine because there's some questions about the epinephrine may raise blood glucose. There's studies out there that they've done really good studies that showed that none of their diabetic patients raised their blood glucose level, and they gave them all like Articaine or something with plenty of epinephrine. But there's other studies that have showed some, and they're basing it. Sometimes when you base something on like looking at cells and, under the microscope as opposed to like a person, you know what I mean? Sometimes you get different results. So it's something, always use caution, use the least amount. Or if your person is very high, you can always go with mepivacaine, but you don't have to be terrified of epinephrine with your diabetic patients. Hopefully I'm not going against what Monica or Gail have told you. But I mean, I have read studies on it, and it doesn't seem like it's something to be terrified of. It's something to be aware of. Oral and injectable. So medications. So there's tons of different medications for diabetes. You have your hypoglycemic medications like the biguanides, metformin, glucophage, the sulfonylureas, the alpha glucosidase inhibitors is another one. And then you have your injectables. But like I said, there's so many of them. Just know your resources and where you can look them up if you're not sure what your patient is taking. Dental hygiene, process of care, we're on slide 20. Only 37% of type 2 diabetics attain an A1C of less than 7%. So chances are, if you have, especially if they're in their 50s or older, if you have them in their chair, unless they are just like on it, they probably have a little bit of a higher A1C. So it's hard for them to manage that sometimes. So just be aware of that. And infection can profoundly disturb glycemic control. So that's why it's like, should we, shouldn't we? Because if they have an infection anywhere, infection in the mouth or an infection in their leg, it's going to make it harder for them to control their blood glucose. Infection is the most precipitating factor in severe ketoacidosis. That's when they have too many ketones in their blood, and their blood becomes too acidic, and the body doesn't like that at all. And then poor diabetic control may aggravate oral disease status. Obviously, that goes hand in hand. There's that bidirectional relationship between diabetes and a healthy mouth. Stress can contribute. So if they're stressed, so that's why it's good to assess these things with your patient. Is your patient coming in stressed? Are they feeling calm? Are they relaxed? Can I help them with anything? Because if they are feeling stressed, that's going to affect their blood glucose. And then vitals for diabetics, you always take vitals on everybody, but to understand their susceptibility to periodontal infection. So when you're going over the health history, so let's see, he's going to come in. When he comes in, we'll take a break. And then, so I'll go until he comes in, and then we'll take a break, like a 5-minute break, and then we'll try and quickly finish up these slides, and then we'll do the activity. Okay, so with your health history, so you want to assess the risk of the undiagnosed diabetes if your patient is high risk. So it's just getting used to like looking at their medical history, talking to them, asking them some questions, and recognizing some risk factors. There he is, right on time. Okay, so you guys take a 5-minute break, and then we'll come back and finish up the slides. And then we'll do the activity. Did I do this slide already? Oh, no, I don't think I did this slide. So I think maybe I said the first bullet point. So assessing the risks of your undiagnosed diabetes, patients with diabetes, and if they are high risk for diabetes. So the CDC does recommend dental offices administer an A1C test. I don't know if anybody's doing an A1C in a dental office. I know that in all the years I practiced, we didn't do blood glucose, which is so easy. I mean, you guys do it, so you know it's super easy. And I think more offices are going to be doing that. They're going to be doing blood glucose. As far as A1C, that would have to be like there's like a certain type of dentist that loves the oral systemic relationship and is a very like proactive, wants to know all the things. If you work for a dentist like that, they may do A1C, but majority of dentists, I can't really proceed adding that unless that was some kind of a requirement, but it certainly would be helpful information for sure. And Kaiser, places like Kaiser, you work for Kaiser, you're going to just be able to pull up that's the great thing about working for these companies that have those healthcare systems where you can see the medical side. In the aging population, traditional symptoms don't always manifest in a typical way. So you have to be a little bit more, sort of a little bit more of a detective with your elderly patients. And then also in the aging, clinical findings are related to chronic complications such as vascular disorders and neuropathic syndrome. So obviously they're just not as resistant to anything that happens in the body that's negative like this. So they're gonna manifest these conditions more, the elderly will. Okay, so your health history interview. So these are the kinds of things you want to be thinking of and talking to when you are looking at your health history. These are kind of your practical applications. You want to be aware of the type of diabetes. I mean, that should be first thing. Do they have type 1, type 2? Methods used to control their diabetes. What kind of medicines do they do? Is it just lifestyle? Maybe they are very early and they're just doing lifestyle changes and checking their blood glucose frequently. Medication schedule and dosage, are they good about taking their medicines at regular times? Date and results of their last A1C. Sometimes you really have to nag your patients for that information. Frequency of self-monitoring of blood glucose. Sometimes, you'll say to patients, when did you take your blood glucose? And they're like, oh, I take it every morning at this time. And other times they're like, oh, I don't take it, and you can just tell they're not as on it, and other people are very regimented. So you just want to get a feel for that. Fasting blood glucose levels, that might be interesting. They're nice to have results of their self-monitoring, the trends, as well as the times of the as those of the day of the appointment, trends as well as those of the that my sentence was strange there. But anyways, the results of what they're monitoring for themselves when they take their own blood glucose. Blood glucose levels 2 hours after meals, and then date of last hypoglycemic episode if they had like a medical emergency type situation. When did that happen and why? Sometimes it's nice to get a little background information on what led to that. When they first were diagnosed with diabetes, and then the regularity of how often they see their physician. Levels of blood glucose for care planning. So if it's under 70 milligrams per deciliter, that's too low, that's hypoglycemic. You want to provide some carbohydrates, 15. I don't expect you to measure out 15 grams of carbohydrates, but give them some sugar, wait 15 minutes. If condition continues, check with the physician and kind of risk assessment of the situation. 70 to 79, monitor at least once during the dental care. Ask them how they are, if they're feeling shaky, just frequently ask them, I ask my patients all the time, how you doing? How you doing? You still there? Even if they're like totally healthy, normal people, I'm just like, how you doing? It's just a nice thing to check in with your patient. 80 to 149, that's sort of in the normal-ish level. Above 150 to 200, that's higher level, monitor infections, insulin intake, their stress, their food intake. So that's when you want to think, okay, they're in this hyperglycemic range. How's their mouth looking? How's their oral health? How's their gum tissue looking? And then over 200 is too high, tendency toward hyperglycemia, check with physician, and a risk for an emergency situation. So when to consult the patient's physician, these are just some things to kind of give you some awareness of when you're supposed to reach out. You want to just, when you don't know your patient and you don't know their controlled level and all these things, you might need to reach out to the physician. Complications such as renal disease or cardiovascular disease, you're going to want to talk more to physicians when you have patients with other comorbidities, especially if those comorbidities are not well controlled. You want to have more of a relationship. If someone has prescribed insulin, you may need to reach out to the physician and just have a chat about that. Lapses in good medical management if they haven't seen their physician for a while. Indications for extensive periodontal or oral maxillofacial surgery. So if someone's coming in for something really big, some big old surgery, you may want to reach out to the physician and have a consult. They are going to be, people who have diabetes are going to be more prone to certain oral conditions, infections, disorder issues, diseases. And here is a non-exhaustive list. There's other things I'm sure, but these are some of the main things. Chelosis or angular cheilitis, that fungal infection and irritation in the corners of the mouth. Xerostomia, there's gonna be dry mouth glossidynia or burning mouth, just inflamed tongue and oral mucosa. Enlarged salivary glands, increased incidence of lichen planus, increased glucose in the saliva if they're so then that can in turn with the xerostomia result in higher levels of decay. In general, they're more prone to candidiasis or thrush, periodontal disease, and then oral ulcers, slow wound healing. They may not heal as well from a big SRP. It might be slower to heal. Yeah, McKenna.
Oh, sorry, just going back to the previous slide, why do we have to consult our physician and prescribe it?
Just to kind of get an idea of their stability. I think like when do they take it, or how is do they have big fluctuations in their glucose? Are they pretty stable? Because type 1 is a little bit more scary because they can have go into an emergency probably more likely than type 2. And so it's just good to kind of like touch base, I think, especially if it's a new patient that you haven't seen before. Increased caries risk, they have the decreased salivary flow and increased glucose, all of these things. And if they snack a lot or eat like the higher carbohydrate, refined carbohydrates, all of those things are going to increase their risk for caries. So diagnosis and planning, protecting patient from health risk and diabetic emergency, that's meeting a human need. You guys remember those human needs, free from this and free from that. So you want to keep them free from a health risk of a diabetic emergency. Reduce their stress level so patients don't have a higher level of endogenous epinephrine. Like if they're stressed, they're going to just have more epinephrine running through their bodies because they're producing it. So you want to try and meet their needs and help them relax. And brief morning appointments are best, considered medications and eating schedules. So one thing that you guys are going to find in this class is that almost every correct answer for when should my patient come in is a brief morning appointment. So that applies to so many. And that's not really always, that's the majority of times. That's a good time for patients. People feel more awake. They might feel more calm. End of the day, rushed and tired. It kind of makes sense for a morning. But, you know, some people are going to be like, I prefer right after lunch, and that's fine too. But in general, that's morning appointments. You want to try and avoid long appointments, and hopefully they will have eaten 1 to 2 hours prior to seeing you. So if they come into your chair at 8 o'clock in the morning and they didn't eat anything, that's not ideal, but trust me, it happens a lot. Consider when patient took their medication. SRP and periodontal debridement are contraindicated if they're uncontrolled. But this is sort of an ongoing question because it's like, well, what if they can't, you know, what if one thing is affecting the other and this circular relationship is making it hard for both their periodontal disease and their diabetes to be stabilized. But in general, if they are way out of control, they want to get their blood glucose down before they see them. Consult and refer to a physician. So here are some big take-home tips, big client education tips. You want to really have your understanding of the relationship between out of control glucose levels and uncontrolled periodontal disease or difficult to control periodontal disease. You really want to have that relationship in your head so that you can talk to your patient about it in an easy to understand manner. So that's a big thing. It doesn't have to be super complicated on some major, you know, cellular level. It's just really getting that message across to them that these two diseases make each other worse. So you really want to get them under control. Greater risk of infection and increased healing times. So of course that says again why they're higher risk for periodontal disease infections, and the healing time could be slower. Inform the patient with diabetes and periodontal disease that their glycemic control may be more difficult and that they are at a higher risk for other complications such as cardiovascular and kidney disease. So these are some major take-home points that you want to share with your patient. Teach the use of daily subgingival irrigation, saliva replacement for dry mouth. Discuss the maintenance of dentition for chewing healthy foods. So periodontal disease leading to tooth loss leads to a diet that's not ideal, you know, and that's for anybody who loses their dentition. You just don't get to chew apples and carrots like you used to, and that's part of a healthy diet, which affects type 2 diabetes. So there's that connection there as well. Individuals with diabetes may not tolerate dentures because of their oral condition. So they might not be thinking into the future. They're not thinking, they might be like, oh, well, if I lose my teeth, I'll just get dentures. But they don't think about how because they are a person with diabetes, that they may not tolerate dentures as well as the next guy. So it's helping them look into the future and see these connections. Oral health contributes significantly to long-term systemic health in patients with diabetes. So again, that's important information. Patients, so this kind of just revisits all those just a little bit. So, you know, monitoring their health, dietary, nutritional counseling, xylitol, salivary replacement therapies, and so that's a little bit repetitive there. Well-controlled diabetics typically do respond well to SRP. So just because they have diabetes doesn't mean they're hopeless. If they are well-controlled, they take their medications at time, you know, the same time, their blood glucose doesn't fluctuate crazy and stays fairly low, they actually can respond very well. So it's not hopeless by any means. Delayed healing may indicate hyperglycemia, frequent recare intervals. So we'd like to encourage like 3 months. So if you have a patient that's diabetic, you should encourage like 3-month intervals unless they go for a very long time, just being super well controlled, then go to 4 and then go to 5 and then go to 6. And so that's how I always went. I would just move it out a month. And if like, you know, a year goes by and they're super stable, move it out a month. Another year goes by, they're super stable, move it out a month. And it helps their pocketbook and it rewards them a little bit. But some people want to come in every 3 months. They don't care. They just want to come in every 3 months. Carefully record all data, treatments that are planned, and performed, any relevant information and recommendations given to the patient. And then here is just a little bit more information about hypo. We got the number again here, 70 milligrams to deciliter or below. Most common metabolic emergency that individuals can have, even type 2, it can be that way too, but type 1 for sure. And it gives it a little bit of what to do, give them juice and carbohydrates. And they would need an injection if they go unconscious. 1% death rate, much lower than years before. So things are much more controlled with hyperglycemia and ketoacidosis or the diabetic coma. Infection is the most common precipitating factor. So if somebody has a major infection, i.e. periodontal disease that's out of control, they are at a much higher risk of having a diabetic coma. So that's, you know, good information to share to with your patients. So there's some information there, severe hypoglycemia versus diabetic ketoacidosis versus diabetic osmolar syndrome, which is something pretty rare. And that's the last slide. Okay, where are we? So we have, oh, I thought I set a timer, but I guess I set an alarm, so it's not a countdown. So we have plenty of time. So yeah, questions.
So in your notes on the slide before this one, it says
Oh,
that tremors is a sign of hypoglycemia, but then on our quiz.
So yeah, it's in the textbook, tremors was on the hyper, but so it's probably just my interpretation, like, you know, when somebody, so you can take that out. So official tremors, it would go with hyper. But so what I'm probably was interpreting without really thinking that it would be confusing is like just jittery. Like you can feel shaky,
Yeah.
but that's not like a tremor. So sorry, I'll change that in the notes. Thank you for catching that. Any other questions? Yeah. Hypo, because with hypo, you can feel like sort of shaky and clammy, and it kind of gives like a nervous feel, I feel like anxious, but not everyone will feel all of those. But I think, I mean, I didn't physically shake, but I felt shaky. You know what I mean? So, so let's pass this out, and you guys can work just you can work independently, you can work at the table, you guys can talk. This is group work, so you guys can talk about this, and we'll I'm trying to get half and half here. And then after you guys have filled it out, then I'll go over it. Hopefully I'll have 5 minutes at the end to go over it. Yeah, you just take one and pass it along. It's front and back. So the case is on the front, and there's like 4 questions.
Is there a separate button to activate this one? Or it's coming along with it. Oh, this is a difficult one. I'm sorry.
Oh, that's okay. I know I remember the guy who did it last time. He was like, this one is tricky.
Yes, yes. I remember this one is a lot easier.
Oh, they're different on the inside. So the white is just the casing.
Yeah, the railing in this one is looser, so it's very difficult to hit the right spots because there you can't see them.
I wonder if that's why it shakes, because it's loose. Something's loose. Although it doesn't look like it's shaking now.
It's okay. We don't have to.
That's awesome.
Yeah.
It looks.
I'm going to terminate the name as well.
Okay. Oh, move it up. Yeah. Although this could be, you know, this is something like I said. So that might be the quality of this. I think that would be all.
I'm very listening to this, because I actually remember something. I think it's the moving mouth drive for 3 months. And then it's
Yeah. And really, yeah.
Yeah, so.
Oh, anytime.
And maybe like more than they can do.
You're gonna tell your patient. "We have a bunch of weird stuff."
Oh my God.
What's happening?
Now, if there are. Not, asthma,
I just looked at my main screen and it doesn't, I think it's a bad. So I got it off.
no, yeah, is there anything else we just, no,
Yeah, thank you. And just as a reminder, this is the thing that I'll collect at the end. So if you're working in a group, everyone fill out their own form, but you can talk about it. And put your name at the top too. They should have had a name section. Oh my word. You'd think after teaching it for 2 years, that would just be at the top of my brain. But it is, yes, it is an asynchronous. Yeah. Does anybody, oh. Yeah. Yeah. Is anyone else missing one? Does everyone have a copy? Are we missing anybody today? Do you need one, Chloe? No, it's fine. Everyone has to write it aloud. Well, that is something that we now we see like the right next down it's usually not like off the forefront of unless there's some kind of help. So you can write that down, but as far as customer it's automatically flag.
really out of order. I feel like you could have made it more in order, just like.
Oh, what you wrote?
You filmed it.
Just dumped everything that was in your brain.
So. This has, this big thing here, that was on the side. It's on college, we provide two avenues. I'm here, sir.
I think there was a few floating around. It's probably based on your patient's comfort. So, yeah, so that is a great critical thinking thought. And this is what I want you guys to do is kind of think of it. It may or may not apply. Maybe based on your feeling.
And then, I said like, the morning. About 2 o'clock, how to irrigate pocket. The doctor's. Right. In the soil. And then maybe like, and then also with the doctor about the cough or something, maybe they can. They have like that. Yeah. Yeah. What about like, you, so like, since they have diabetes? Would you, I feel like a consult with the doctor.
Like the medical doctor or the dentist?
Yeah.
I guess with the doctor, I guess.
What it does say, but I'm, you know,
You can, I know, you can, so in a private practice, usually the rule of thumb might, if the patient is really, that, like, if they're not controlled and they're like a pretty sick patient, and the dentist is aware of this too. It's not like this is on your own. Like, they're aware of the patient's pretty sick. And if your doctor doesn't seem to be tracking, you know, you can say, what about this patient, you know, and then the two of you can talk about whether or not it's pretty important to call the physician. And just, it could be as simple as, I have this patient, our mutual patient in my chair, we're gonna do this. Do you see, I'm a little bit concerned of this, this, and this. Do you think there's any issues? But, and in case the doctors don't know about things that are connected to oral health, so you might be educating them by just calling them, calling the physician, but it also gives an opportunity for them to say, oh, I think that's fine, I don't think there's anything wrong there, or, yeah, I would be cautious using this, or, you know, whatever the situation is. So, but as far as your protocol for our clinic, did you?
Is there like a thing?
I was down there.
So that.
I know, exactly, continue to hear me. Oh.
I don't know.
So, and the only thing I can think of that it means, and I get a little confused, but that's what I've been told, is that you I think, you need to check Polly and Gail, but I think it needs to literally call the position, try and get a current A1C and, but the actual people.
And I was like, oh, she got it, but then she said that she does, like, she just, she just said that she refers or doesn't.
It could be that it is just, it could be that it's just taking the liability off of you and you telling your patient, you need to keep in contact with your physician. I'm just letting you know, now the ball's in your court. I'm not really sure what that means, but I think do you guys have Q&A or something with Gail and Holly? So actually, clarify.
Yeah.
And I'm gonna ask, Holly, too. I should probably know too. Yeah. No, for sure.
I don't know, we haven't done it that much.
Well,
I'm not.
yeah, no, your patients, going from junior spring to fall senior, your patients will jump in their health histories they'll be much more medically compromised and their perio will be worse. So I know everything is like after Algilla, where of course like, I mean, it's like, it's kind of like, yes, you numb them up and then you go to town. And just try not to be too rough because inflamed tissue can flop and you don't want to be flopping too much. You don't want to do sunlight. You don't want to delay. Oh my God. Yeah, but people go for like years without knowing they have diabetes because they are and they are you guys getting close to having finished the writing part? We got about, oh my gosh, we only have 7 minutes. Okay, so I'm just gonna start so I was telling, I was saying that it's not, these answers, if you have something like way wrong, you'll want to cross it out. But in general, some of these things are not necessarily going to be like black and white, right and wrong answers, because you can have a patient in your care that might respond this way, or this might be happening. These are hypothetical cases. And so I might have some that are a little bit more black and white, but sometimes it's just kind of like, I don't know, maybe this is happening. I might have to do that. And so it's just getting you kind of thinking about the scenario. So like the first question, based on her diabetes, what are some of the main accommodations to be aware of when treating this patient in the clinic? So what are some things that you guys thought of? Yeah.
Need to contact their clinician,
Mhm.
to get A1C or an idea of that.
Yeah. So you're gonna want those vitals, you want the A1C, talk to the physician. Yeah, Madison? Early morning appointments, probably. I mean, and again, you can keep it open to them if they want to come in later, it's fine, but oftentimes a morning appointment. Taylor?
So what the patient ate and what was the last time they took their medication?
Yep, you want to know eating time, medication time.
For this patient specifically, B/D, I don't know, they have hypertension, so make sure that you set them up slowly, give them a second.
Yes, orthostatic hypotension, perfect. That's gonna be something to think about for sure. That's great. Yeah, yeah, that's a good idea. So knowing where you're, having your supplies ready, and then also knowing where if we have crackers, if we have juice, if we have the little, glucose tabs, knowing where that is in the clinic so you don't freak out if for some reason you had to use it. Was there a question or did someone have something over here that you can? No, made it up. It was in my periphery. Maria? Yeah, so you might want to talk to the, in our clinic, it's not as likely, but in real life, you might talk to the doctor, the dentist about if this patient would be a good patient for antibiotic. And we talked about pre-med a little bit. I was talking with Maria a little bit about it. Diabetic patients aren't your automatic red flag, like diabetic, but if they it's one of these things where if you wrote it down, it's not necessarily wrong. It's just not in the type, it's not the type of pre-med like a heart valve pre-med. It's more like maybe an antibiotic would be good for them because their infection is really, they have a lot of infection and they're going to have this big procedure. Or like Maria said, the doxycycline might be a great option for somebody who is diabetic. Anything else? Anybody have any other things they're thinking of?
Can we get like a stereotype things in or,
You can use that kind of stuff localized. You could use Arrestin or Periochip, or they have different things like that that you can use localized. Yeah, Liddy?
fluoride treatments or like fluoride, xylitol, like
Yeah. Yeah, so thinking of all of the things that might address different problems that they have. That's
If they haven't been to the dentist for 2 years, maybe have, their anxiety come down a little bit and they have hypertension as well, so explain all the procedures you're doing as you're going through.
such a good point because I mean, if somebody hasn't been in for a while, being able to calmly and gauging their pace, sort of gauging, is going to be really important. Like letting them know what to expect, telling them enough, but not too much. Some people want to know everything. Some people don't want to know anything. And just really getting a vibe for your patient and explaining, especially if they're feeling nervous. Let's do one more. What would you say to help your patient understand the relationship between diabetes and a healthy mouth? Shandy, oh, go ahead, Shandy.
I would explain that. Oh, there. All right, people with, diabetes, especially uncontrolled, have a higher risk or rate of periodontal disease, and that could lead to bone loss, and eventually tooth loss, and by maintaining that healthier mouth, or slowing down that rate of perio, they can chew healthy foods and make better options, or make better choices, so they don't have to resort to eating softer, stickier, easier.
Yeah.
Essentially, that's it.
Yep, perpetuate the cycle. That's great. Yep, that's a really good explanation. It's so good to like practice a script. And I know scripts sound silly, but when you have a simple directive down, and then you can embellish a little bit more. But if you have like this is, and you don't want to sound like a robot, but if you have like, what you're going to say about it, it keeps you like, I do the exact opposite. I just wander and talk and then think, oh, I want to say this. And it's never very helpful, but with your limited time and with an hour, if you know exactly what you want to say, especially when it's a disease process, it helps a lot. It helps a lot. I am gonna, as a clinician, what are your thoughts on the dry hacking cough? So what are you guys thinking about that? It, so medication, dry mouth, dry throat, or the cause of medication, yeah.
Can Parkinson's cause a dry cough?
It could be something with the Parkin, that's great. I didn't even have that on my thing, but it could, I mean, because they do have weak, throat muscles, so it could be that they choke on their saliva if they have some saliva to choke on. So it could be, you know, that's not like a cardinal sign of Parkinson's, but it certainly could be affecting it. So that's very good, yeah. Allergies, and think about like, so if your patient, it does have a dry hacking cough and you know it's not like, they're not like COVID and contagious or have tuberculosis, those are all wet and productive usually. But, but it's, if you know that it's nothing that you need to be like, quote unquote, like worried about, just think about making them comfortable. You might keep water by the chair. They may have to sit up, and take a break if they cough on the water that you're spraying in their mouth. So be aware of their comfort kind of more than anything, but you can also help them address it. If it's their medication, the lisinopril can do that. If it's bothersome enough, they might want to try a different medicine. I'm going to stop there. If you guys would just sort of pass that all forward, make sure your name's on it. And then I'm going to post a teacher version. I'm going to post a teacher version that has all kinds of like extra tidbits that you guys can have and read through. And so if you feel, thank you. And don't forget your quizzes too. You guys can kind of keep those, thank you, in like a notebook or something and keep those for, I don't want to get, for studying and future quizzes. Thank you. I get everybody's worksheet. I don't want you to forget. I do. Because I don't know.